This is another section, metabolic acidosis. Etiology. A low cardiac output state, which is often associated with peripheral vasoconstriction from hypothermia or use of vasoconstrictive drugs, is the primary cause of metabolic acidosis in the cardiac surgery patient. Low-dose epinephrine occasionally causes a metabolic acidosis out of proportion to its alpha agents when the cardiac output is satisfactory. This may reflect a metabolic type B lactic acidosis, not associated with tissue hypoxia, caused by metabolic factors that increase lactic acid production, such as hyperglycemia and lipolysis. 3. Intra-abdominal catastrophes, such as mesenteric ischemia from a low flow state, should always be considered when progressive metabolic acidosis occurs. 4. Sepsis. 5. High doses of sodium nitroprusside. 6. Renal failure, which reduces acid excretion. Acute hepatic dysfunction. 8. Diabetic ketoacidosis. B. Effects. Adverse effects of metabolic acidosis usually don't occur until the pH is less than 7.20. A poor metabolic acidosis, low serum bicarbonate with acidemic pH may be noted in the heavily sedated patient in whom there is no respiratory compensation. However, compensatory hyperventilation to neutralize the acidosis will occur when the patient can breathe spontaneously and for every 1 milliequivalent liter fall in bicarbonate, the partial carbon dioxide is generally reduced about 1-2 torr. However, it is not uncommon to see incomplete compensation with a mixed respiratory metabolic acidosis. Notably, some of the deleterious effects of metabolic acidosis may be related to the metabolic products associated with the acidosis rather than the absolute level of pH. Also, they may be reversed by administration of sodium bicarbonate. The presence of a progressive or significant metabolic acidosis, as assessed by the serum bicarbonate level, is often an indication of a serious ongoing problem that must be corrected before adverse consequences occur. These include cardiovascular effects, decreased contractility and cardiac output, reduction in hepatic and renal blood flow, attenuation of the positive inotropy effects of catecholamines, venoconstriction and arteriolar dilatation, which increase filling pressures and decrease systemic pressures, increased pulmonary vascular resistance, sensitization to reentrant arrhythmias and reduction in the threshold for ventricular fibrillation, respiratory effects, dyspnea and tachypnea, decreased respiratory muscle strength, metabolic change, increased metabolic demands, hyperglycemia caused by tissue insulin resistance and inhibition of anaerobic glucolysis, decreased hepatic uptake and increased hepatic production of lactate, hyperkalemia, increased protein catabolism, cerebral function, inhibition of brain metabolism and cell volume regulation, obtundation and coma. 3. Type A lactic acidosis reflects impaired tissue oxygenation and anaerobic metabolism resulting from circulatory failure. The acidosis is self-perpetuating in that excess lactate is being produced at a time when there is a suppression of hepatic lactate utilization. The lactate ion, probably more than the acidosis, contributes to potential cardiovascular dysfunction. Elevated lactose levels more than 3 millimole liter upon arrival in the ICU are associated with a worse outcome. They are more commonly noted in patients with pre-existing renal dysfunction after long pump runs and with use of intraoperative vasopressors. It is likely that this reflects inadequate oxygen delivery during bypass that can contribute to splanchnic and renal ischemia with the acidosis perpetuated by a low cardiac output syndrome. Needless to say, The presence of elevated lactate levels during bypass or open arrival in the ICU requires prompt attention. The development of a metabolic acidosis several days after surgery raises the specter of mesenteric ischemia, especially in patients requiring additional days of ICU care. Type B lactic acidosis occurs in the absence of tissue hypoxia. It may be a catecholamine-induced metabolic effect, especially with epinephrine, caused by hyperglycemia and alterations in fatty acid metabolism that cause pyruvate accumulation and elevated levels of lactic acid. Acute hepatic failure may also be present with severe lactic acidosis due to failure to clear lactic acid. Metformin is associated with lactic acidosis in patients with renal insufficiency, low cardiac output states, and liver disease, and with use of contrast agents. C. Assessment. Measurement of the anion gap is important is sorting out the etiology of acidosis, with normal range being 3 to 30 milliequivalent. Anion gap is equal sodium minus chloride and bicarbonate. Also, 3 are a number of factors that can influence the anion gap. An increase in anion gap generally reflects additional acid production, and high anion gap metabolic acidosis is what is the most common after cardiac surgery. It may also be elevated in diabetic ketoacidosis due to production of hydroxybutyrate or in renal failure from retention of hydrogen ions. A normal or low anion gap represents loss of bicarbonate, diarrhea, renal tubular acidosis. D. Treatment. Treatment should be directed primarily towards the reversal of the underlying cause. This will allow for oxidation of lactate and regeneration of bicarbonate to correct the acidosis. With a correction of a primary metabolic acidosis, not one that compensates for a primary respiratory alkalosis, should be considered when the serum bicarbonate is less than 15 milliequivalent liter. Base deficit greater than 8-10 millimole liter is controversial. Proponents of bicarbonate administration suggest that severe metabolic acidosis does have significant deleterious effects on cardiovascular function that can be corrected with a more normal pH. Furthermore, more responsiveness to catecholamines does seem to occur with a more normal pH. Thus, correction of the acidosis may be important when the etiology of the acidosis is unclear or not immediately remediable. Others argue that the use of bicarbonate can cause metabolic derangements with little evidence of hemodynamic improvements. So, sodium bicarbonate can cause fluid overload, hypernatremia and hyperosmolarity, increase affinity of hemoglobin for oxygen, and reduce ionized calcium, which may reduce cardiac contractility. It's proposed that bicarbonate may correct only the blood pH, not the intracellular pH, and that the increased production of carbon dioxide that may not be eliminated in low output states may impair lactate utilization, perpetuating the elevated lactate levels. If one elects to correct the pH, there are several compounds that can be used. Sodium bicarbonate is administered in a dose calculated from the following: 0.5 body weight in kilogram, base deficit. This is the sodium bicarbonate milliequivalent. This should be administered over several hours in the patient with severe metabolic acidosis, with careful monitoring of the serum sodium concentrations. Because the bicarbonate is metabolized to carbon dioxide, this can worsen a respiratory acidosis in a patient with compromised pulmonary function.